Good morning, all. So this is one among the first sessions of Drishti 2025. I welcome all of you to this session. So our topic is Red Eye Reloaded. This will be a practical guide to diagnosis and management of ocular surface redness disorders, mainly for general ophthalmologists. So we have divided the topic into lid-related causes of redness, conjunctiva-related causes, cornea-related causes, again divided into infective and non-infective. So first we have Dr. Miriam Joseph, who is a phaco-refractive surgeon working at Arya Eye Care Hospital, Thrissur. Dr. Miriam will be presenting on beyond pink eye, conjunctivitis, drug-induced and cicatrizing conditions.
Good morning, all. So the topic given to me is beyond pink eye, conjunctivitis, drug-induced and cicatrizing conditions. So this presentation, I mainly want to give the message that everything we see as a pink eye is not pink eye. It can be drug-induced or cicatrizing. So just to make us aware of all the rare conditions which we can misdiagnose as conjunctivitis. So conjunctivitis is inflammation of conjunctiva. The main symptoms are lacrimation, grittiness, stinging, burning, and if there is pain and photophobia, we should suspect corneal involvement. Discharge, which is a main thing which we can differentiate between all these causes, is watery. If it's watery, it's viral or allergy. If it's mucoid discharge, it can be chronic allergy or dry eye. If it's mucopurulent, it can be bacterial or chlamydial conjunctivitis. If it's severe purulent, it can be usually caused by gonococcal infections. Now, just a quick walkthrough of the signs. Ciliary congestion and circumciliary congestion, we all know how to differentiate. Ciliary congestion is mainly in the palpebral area. The caliber will increase towards the periphery, and if we put topical phenylephrine, it will disappear, unlike the circumciliary congestion. So follicles are small, discrete, elevated lesions resembling grains of rice. They are usually seen in the fornices. Papillae are usually seen in the palpebral and the limbal bulbar conjunctiva. They have a vascular core. They appear like mosaic-like pattern of elevated red dots. The causes for this are usually bacterial allergy, contact lens wear, chronic marginal blepharitis. This is just a picture which shows how to differentiate between a papillae and follicle. Because the papillae has a vascular core, it will appear as red, raised, elevated dots, and the follicles will resemble grains of rice, and the blood vessels will be around the follicles. Now, some conjunctivitis can present with hemorrhages, usually viral. Chemosis can also be a presenting sign. Now, coming to membranes, they can be pseudomembrane or true membrane. Pseudomembranes are basically inflammatory exudates, and they can be easily peeled off from the underlying conjunctiva without any bleeding. But true membranes are integrated into the epithelium of the conjunctiva, so they will bleed when we are trying to remove it. That's how we differentiate a pseudomembrane and true membrane. Now, a feature of cicatrizal conditions are subconjunctival scarring. They can be seen in trachoma as a sequelae of membranous conjunctivitis, and severe scarring can lead on to cicatricial entropion. Another feature is preauricular lymphadenopathy. It's usually seen in viral conjunctivitis. Now, antibiotic therapy initially, and we have to provide adequate lubrication. Antibiotic ointments can be given at night to prevent the sticking, and peeling of membranes if present, and steroids can be given with caution, especially if there is membranes, to reduce the inflammation. Now, an entity called chronic bacterial conjunctivitis, which we tend to miss. This we usually tend to miss as allergic or as a chronic viral. In chronic bacterial conjunctivitis, it is usually associated with blepharitis. So we have to see the lid for this. And the most common cause is Staph aureus. Moraxella can cause chronic angular blepharoconjunctivitis. That is, there will be angular inflammation here. And we have to see the lids on all conjunctivitis patients if there is marginal ulcers in cornea. And the treatment is basically with good lid hygiene. Unless we give good lid hygiene, this condition is not going to resolve. And we can give oral doxycycline in severe cases. Something else called hyperacute bacterial conjunctivitis. This is usually seen in neonates and sexually active young adults. It's an oculogenital disease caused by gonococci and meningococci. It has profuse, thick, green-yellow discharge, painful hyperemia, tender preauricular lymphadenopathy. And if untreated, they can have corneal complications. And the treatment is basically we give topical therapy along with systemic antibiotics. That's a must in this condition, otherwise it will not resolve. Now coming to viral conjunctivitis. Basically we all know that viral conjunctivitis is basically we give supportive treatment and we need to educate them on hand and ocular hygiene to prevent the spread to the other eye or to others. And basically the treatment is mainly lubrication and cold compresses, topical steroids if they have subepithelial infiltrates. Now another one called HSV conjunctivitis, that is herpes simplex virus conjunctivitis. It's usually seen in children. It is usually associated with these vesicular skin lesions around the eye. That's the pointer towards HSV conjunctivitis, and they will have preauricular lymphadenopathy. It usually resolves spontaneously. We give supportive measures. If the cornea is involved, we have to give antiviral therapy. Now coming to allergic conjunctivitis. It can be acute allergic conjunctivitis which is usually seasonal or perennial, and the differentiating features are papillae, chemosis, and they will have this mucoid watery stringy discharge. There is an entity called chronic atopic conjunctivitis, that is AKC. It is usually seen in the late teens to the 5th decade. So it's a later onset allergic conjunctivitis. They have a history of eczema or asthma, and we usually see a lower tarsal papillary hypertrophy, and they can have upper tarsal cobblestone papillae also. Another entity is the vernal keratoconjunctivitis. These usually affect children and young adults, and they also have a history of atopy. It is usually exacerbated in the spring and summer months, and they have upper tarsal papillary hypertrophy, and cobblestone papillae can also be seen. Here the classic in limbal VKC we will see these broad thickened gelatinous thickening of the superior limbus and Horner Tranda dots, which are the white dots that you see on the superior limbus. That is how you differentiate VKC. Now cornea can have superficial pannus, punctal epithelial keratitis, and shield ulcers, which you can see here. This is a grading system. We just need to know when to refer them to an allergy specialist. We will treat the eye part, but they will not get better unless we start the systemic therapy also. That is what we need to know in allergic conjunctivitis. So treatment is basically based on severity and chronicity. We provide, we tell them cold compresses, preservative-free lubricants which can be refrigerated, because they can apply these cold refrigerated lubricants whenever they feel the need to it, so that they can avoid eye rubbing. The drugs that we give are usually mast cell stabilizers like cromolyn sodium, antihistamines like olapatadine, alkafetine, bepostatin. In seasonal allergy conjunctivitis, when we know that the season of allergy is coming, we can give them pre-treatment with these anti-allergies. Then in severe cases in VKC atopy, we need to give them immunomodulators like topical cyclosporin and topical tacrolimus ointment. Corticosteroids are another mainstay of treatment which we need to give. So when to refer to allergy specialists, that is grade 2, 3 in VKC. That basically means that if they have persistent symptoms, even with treatment, corneal symptoms, corneal signs, then we need to refer them to an allergy specialist. They need systemic anti-allergy treatment for their condition to resolve. And if they have associated systemic features and a history of other atopy. Now another entity called allergic dermatoconjunctivitis. It is usually an allergic reaction to topical medications, cosmetics, clothing, jewelry, anything can cause this. This presents with usually severe itching and inferior palpebral papillary reaction, and they have this lower lid and canthal eczematous reaction. That is how we differentiate this. And this can go on to lid keratinization and punctal stenosis if we don't treat it. And how do we treat? This is an allergic reaction, so we eliminate the stimulus, we discontinue the medication or the cosmetic that is causing it, and we give topical antihistamines and steroids. Another entity called microbial allergic conjunctivitis. This is a new term, but we all know what it is. This is usually caused in a chronic staphylococcal blepharoconjunctivitis. It can be associated with marginal keratitis. Flicton is also another entity in this. GPC, that's giant papillary conjunctivitis in soft contact lens wearers we usually see in ocular prosthesis and protruding sutures. In this, we remove the inciting factor. This is similar to the allergic dermatoconjunctivitis, that is toxic follicular conjunctivitis, usually seen with topical medications, or molluscum contagiosum, which is seen in the lid margin, pityriasis pubis on the lid margins, cosmetics. This also we discontinue the medication or we treat the underlying condition. Now come a few slides about the cicatrizing conjunctivitis conditions. That is, one is ocular cicatricial pemphigoid. This is a chronic progressive condition. We need to have this suspicion in our mind when we see a chronic patient of conjunctivitis, because this is a progressive condition which can go on to cicatrizing complications. Now another is Stevens-Johnson syndrome, which is, we all know it's caused by allergic reaction to drugs. Usually it's non-progressive. That's the differentiating between the OCP and the Stevens-Johnson syndrome. I'm not going into all these details. Another which I want to say is the drug-induced cicatrizing conjunctivitis, which has cicatrizing sequelae. It is not just a conjunctivitis. If you don't treat it, it can go on to cicatrization. That's all. Thank you.
Thank you, Dr. Miriam, for that long list of differential diagnosis. Though conjunctivitis is a common word and a common topic, this was an insight that there's a lot of differential diagnosis for conjunctivitis. Next, I welcome Dr. Nadna Bashir, cornea and phaco-refractive surgeon, Arya Eye Care Hospital, Thrissur. Dr. Nadna will be talking on when the cornea is under attack, keratitis and corneal ulcers.
I am very happy to see so many of you attending this session. So red eye is always a very common condition which comes to our OPD. Often corneal conditions like corneal ulcer and keratitis are easy to diagnose because the patient will be already in a state of photophobia and pain. So we'll go to the topic directly. So the cornea is the outermost layer where it is very prone to the external insults and injury, and it's densely innervated. So even a small injury can cause a lot of distress to the patient. Red eye often, due to corneal pathologies, may be overlooked and sent back. So careful examination is always prudent. Coming to the global burden, around the prevalence rate we have found us around 113 per 100,000 population in the South India. And in our population, it is more of bacterial and fungal. And the high incomes countries like the developed countries, the range of infective keratitis is much lesser than our part of the world. Coming to etiology, it can be both infective and non-infective. I'll be mainly dealing with the infective pathology. So these are the risk factors for developing a corneal injury or a topical medication which is injudiciously used, like a topical steroid, use of contact lenses, unhygienic practices, or often after surgeries following LASIK or penetrating keratoplasty. So we know the features of a bacterial ulcer. So there will be the symptoms will be more, and it will be wet ulcers. It is often with a grayish white or yellowish infiltration. Mobile hypopyon is usually present. In case of a pseudomonas ulcer, we can see surrounding cornea having a ground glass appearance. Coming to each ulcers, which is we can point out as a telltale occurrence. So this is at intrastromal abscess seen in staphylococcal ulcers. This is a ulcer serpens, which is seen in the pneumococcal ulcer, where one part of the ulcer will be progressing when the corresponding other side will be healing. It will have dense AC reaction and a large hypopyon usually. Coming to the gram-negative ulcer, most common is the pseudomonas ulcer. Often we see in patients with contact lens use. The feature of this ulcer is a rapidly progression of the ulcer, and it extends to periphery and deep stromal layers very fast. It can often present as a ring-shaped ulcer. Usually the treatment is 45 to 2.5% of amikacin. And then this is the ulcer, which is not very common, but it's a very indolent ulcer. With a minor trauma they present, and with normal medications it won't respond. And it has a characteristic feature, which is the pinhead lesions at the periphery and having a wreath-shaped in appearance. So how to identify this, you have to use a ZN staining method, and they are identified as long, slender, branching, gram-positive rods. Here also the medications we use is the amikacin. So grading also, it's usually 1, 2, 3 rule. So here the infiltrate size represent the 1, which is if it is up to 1, we can treat it with the monotherapy with the fluoroquinolone. Second is 2 millimeter. 2 stands for 2 millimeter within the visual axis. So in that case, we can consider fortified. Always while considering fortified drops, we should always be aware of the toxicity it can cause. So when you're responding to a normal monotherapy, why to start a fortified antibiotics? Always keep that in mind, because toxicity also can damage cornea and increase the epithelial defect and stromal melting. So common fungus that causes ulceration is the Fusarium, Aspergillus, curvularia. So features are again dry-looking ulcers with feathery margins, yellowish-white infiltration, and immobile hypopen. Certain cases of fungus like curvularia bipolaris, they produces pigmentation. So I'll just discuss a small case which has come with a stick injury, 67-year-old with no history of any diabetes. She developed an fungal ulcer. So presentation was around, the visual acuity was around 3/60. She was treated with natamycin, voriconazole, and itraconazole, and patient improved after 1 month of therapy. This is another case. Here I wanted to highlight the patient had an injury with the insect injury, and the patient was presented to me with a lot of medications already started from elsewhere. So it had an irregular appearance. So we'll often confuse fungal for viral. So viral antivirals were also started from. The problem with starting all of the medication, patient will be very less compliant. So what happened is I asked the patient to stop antivirals and asked to continue whatever drugs was given. And actually the patient improved. So it's not that you have to start so many of medications. First identify if it is improving with the minimal therapy, you can continue with that. So you should always keep in mind that it may be a non-compliant patient. Always ask for the drug history. Next, coming to the microsporidial keratitis. This is very common nowadays, especially in the rainy season. We are seeing a lot of patients with this classical stuck-on appearance, which we see. And some patients may have an anterior chamber reaction. Most of the condition we have to believe is the self-limiting. So most of the condition doesn't need any too much of treatment. And if at all possible, we can add lubricants, lot of lubricants and antibiotic. In case of limbitis, anterioritis, and endothelitis, you should start a steroid. And fluconazole is freely available, and you make use of fluconazole in case you feel it is a microsporidial keratitis. Coming to pythium keratitis, it's a very rare condition, but it's a very severe condition. So here there is a tentacle-like projection in the ulcer, which is not some fungal ulcers which does not respond to normal antifungals. You have to think of this case. And the identification of zoospores is the gold standard. And the treatment is 0.2% topical linezolid or 1% azithromycin. So here I wanted to tell this patient a sustained injury with thorns and developed fungal ulcer. Patient had been treated with the thorns were taken, most of them were taken, but patient was treated with antifungus, but patient did not improve. When we checked again, actually my retina colleague had seen this, so she referred to me. I saw a small foreign body was left behind. She had taken almost all the other parts, only one was remaining, and that was the reason for the ulcer not healing. So always think of a retained foreign body in case of an injury. Coming to viral ulcers, so herpes simplex virus can have a primary herpes and also secondary herpes. What happened is these herpes always have a latent infection, which the dormant virus will remain in the trigeminal ganglion. These are the various features that can occur. Reactivation can occur due to stress, sunlight, immunosuppression, any topical medications like prostaglandin analogs or a systemic steroid, any ocular procedures like LASIK or a cross-linking. So according to the head study, they have told that steroid should be used in case of stromal keratitis. And in case of stromal keratitis, there was no much benefit with starting an oral acyclovir. Whereas in an iridocyclitis, it is often prudent to start a oral acyclovir. And a long-term prophylaxis study was also done with the heads too, and they found that acyclovir reduced recurrence risk by around 40%, which is a very, but it should be given for a long period, like 1 or 2 years minimum. That is acyclovir 400 milligram BD dosage. Okay. Now coming to herpes zoster in keratitis. So this is again, we will have a rashes affecting one part of the face, and it's always present as can affect cornea as pseudodendrites, nummular keratitis, disciform keratitis. Always you should have a history of herpes zoster or a herpes infection previously. The Z study has recently published as telling a long-term prophylaxis for valacyclovir in a low dose can be continued for 1 year for preventing recurrences. Coming to acanthamoeba keratitis, this is again, there are 2 types. Mostly it is epithelial pseudodendrites or ring infiltrates or a radial keratouveitis. So we have to do the scraping and culture to always come to a diagnosis. This is a simple case which came to us with a pterygium. He was asked to excise the pterygium. He went to an Ayurvedic specialist and did some Ayurvedic treatment, after which he developed a yellowish infiltrate, which was a fungal infiltrate. And it was actually, we were giving the antifungals, all topical medications and orally, but the patient, the ulcer was increasing. So what happened is, after this appearance, we started to give an azithromycin. That is, we try to treat the MGD along with it. And what happens is, we can see the ulcer started regressing. Thereafter, ulcer got into control. So what I wanted to say through this is that the ulcer is a vast topic, so we can't cover it within a very short time. But what I want to tell is, always check if the ulcer is not responding. Always check for the adnexa. Always check for a retained foreign body. And if not identified by you, please refer to a cornea specialist so that these can be picked up easily. Thank you.
Thank you, Dr. Nadna, for covering that intense topic in such a short time. Next, I invite Dr. Aneshwara M. John, cornea consultant in Vasan Eye Care Hospital, Thrissur, for her topic on non-infective yet red cornea, miscellaneous causes.
So my topic is non-infective keratopathies. Again, this is a long list. So I'll be talking on how to diagnose and what is the initial management. So non-inflammatory keratopathies diagnosis is mainly by topical antibiotics, lubricants and steroids. What, when, where, how and which are required are the questions to be answered. A few words on lubricants. I would prefer dexpanthenol and sodium hyaluronate whenever there is a disease process in the cornea because of its corneal epithelial friendly behavior. No financial interest. Let's start with SPK. SPK mainly seen in viral and microsporidiosis. In viral, it will be like a small dot with surrounding haze, whereas in microsporidiosis, as Natna said, it will have a stuck-on appearance. Still, it might be confusing in some cases, so check sensation. Sensation will be reduced in viral. We can also scrape the stuck-on lesion and send for the microbiologist if you have an option. Coming to treatment, viral, actually there are 2 schools of thoughts, but I go with the steroid school. Start with dotiprednol, tapering over 5 days with lubricants. Microsporidiosis, best respond to topical fluconazole. Start with 8 times a day. If there's a lot of stromal haze, can start steroids in the first visit or wait for 1 week review. If the lesions are not resolving quite fast or the patient complaining of foreign body sensation and if the stromal haze is persisting, start with dotiprednol. SCK, again, inflammatory of the viral. It shows a minimal stain uptake. There will be more of stromal haze. Coming to management, in the active phase, steroids are required. So again, start dotiprednol, tapering doses. Also add cyclosporin, BD dosage. The SCK scars will fade, but it might take some time, maybe 4 months, 6 months or 1 year. So we can give cyclosporin until the scar fades. There's absolutely no side effects with cyclosporin, so it can be given up to 6 months also. Tygison's keratitis. This patient came with a lot of photophobia. I couldn't get a clear image in any of the frames, so I thought I'll put this video. This is a chronic bilateral, clinically looks like SEK or SPK. So it is the history which help us clinch the diagnosis. They give history of long duration, waxing and waning of symptoms. So here, treatment is similar to SEK. In the active phase, they will require steroids, give loteprednol tapering doses, also start cyclosporin. Continue the cyclosporin for 6 months, stop, and then check for recurrence. If at all recurring, what is the interval of recurrence? And in case of recurrence, again add cyclosporin for next 1 year. Stop and then check. Like that, we can control the inflammatory response with cyclosporin. Coming to epithelial defect, in case of small ED, plain antibiotic drops will suffice like chloramphenicol or polymyxin along with lubricants. In a non-healing ED, or if the ED is taking more time to heal, you can add fortified insulin 4 times a day. Oral doxycycline also will help. And if you are sure there is no infiltration, can give bandage contact lens. In case of neurotrophic keratopathy, most of the time patient comes with a known neurological diagnosis. So along with these medications, autologous serum or tassorafy, depending on the severity of the lesion. This is how the fortified insulin is prepared. It is very easy to prepare. You can ask your pharmacist to do it. The only extra thing that is required is the dropper bottle. Insulin will be available in most of the pharmacies. Recurrent corneal erosions. Sometimes the patient presents with a loose epithelium, but most of the time it is again the history which helps us diagnose the case. Patient will complain of pain and irritation in the morning. History of trauma may be there, may not be there, but again recurrence is the clue which helps us in diagnosis. Otherwise it will be only an ED. So in case of RCE, in the first visit, advise dexpanthenol before sleep, not at night, before sleep. Whenever the patient is sleeping, the patient has to apply that before sleep. In spite of this, if there is recurrence, then add hypersol 6 at night and dexpanthenol before sleep. Again, if it is recurring, give bandage contact lens for 8 weeks along with dexpanthenol. We cannot use BCL for 8 weeks continuously. Every 2 weeks, remove them. Either clean it and reapply it, or you can put a new one. After 8 weeks, remove the BCL, put the patient on dexpanthenol. If still there is recurrence, then the patient will have to go with anterior stromal puncture or a diamond burr. Delen. This happens because of some surface irregularity which deprives uniform distribution of the tear film. So, taping of lids with frequent lubricants is the best choice. Lubricants, again, sodium hyaluronate or dexpanthenol. And if the surface irregularity allows, you can put a bandage contact lens. Permanent solution is always treating the cause. You have to remove the surface irregularity. Exposure keratopathy. Again, patient comes to us with a known neurological diagnosis or a lid-related diagnosis. So what we can do to protect cornea is preferably preservative-free sodium hyaluronate, dexpanthenol, taping of eyelids or wear eye mask at sleep, and tassorafy depending on the severity of the neurological condition. Contact lens induced keratitis. Most of the time patient comes with peripheral small creamy white infiltrates. So this can be broadly divided into infective and sterile. Infective, the patient will have more of pain, AC reaction and ED. Whereas in sterile, there will be no much of pain, it will be more of irritation. In any contact lens related cases, as we know, contact lens abstinence is the first thing to do. And infective cases, start with fluoroquinolones, moxi, gatti or levofloxacin, start early or too early. Sterile ones will heal by itself, but still we can give plain antibiotic drops. Another condition is hypoxia. There the patient will present with epithelial edema, stromal edema with conjunctival congestion. Again, plain antibiotics will suffice, and once it resolves, ask the patient to shift to daily wear type of contact lens. Whether steroids are required in click or not is always a question. Even though clinically sterile looking, studies have shown that many of them has turned culture positive, actually in 60 to 80% of the cases. So it is better to avoid steroids in contact lens induced keratitis, and even if the lesion is sterile, it will heal by itself or it will heal by plain antibiotics. So I don't advise steroids in case of click. Can you point out the lesion? It's a caterpillar hair. Caterpillar hair, when the patient presents, remove the protruding hairs, whichever takes up the stain, remove them. Those which are well within the stroma can be left alone. And always check anterior vitreous face and the vitreous for any caterpillar hair. If caterpillar hairs are present in the vitreous, then the patient will have to go with vitrectomy. If not, again, antibiotic steroid combination. This will cause degeneration of the stromal hairs. So the hairs which are well within the stroma need not be removed. When I say antibiotic steroid, some people think of moxifloxacin and lotiprennol combination, but somehow that will not be sufficient for these cases. I would always prefer dexamethasone combination. Ocupol D is one of the medications which works well for me. Again, no financial interest. PUK is always a confusing and a tricky question. Some clues which help us in diagnosis is that infiltration will be ahead of the epithelial defect. If the patient presents to you quite early, there will be only infiltration, and it is in the later stage that ED develops, and there will be no lucid interval. There will be history of recurrence, peripheral scars, associated scleritis can be seen. These are the clues which help us in diagnosis. When the infiltration is of good volume, it is always better to scrape and check for microbiology to rule out secondary bacterial infection. There are n number of causes for PUK and n number of blood tests, but need not run all the blood tests in the first visit. Check ESR and RA factor. These are the most common ones to be elevated. So if they are elevated, then refer to the rheumatologist. Unless the blood inflammatory components are under control, the PUK will not resolve completely. So if the stains come negative, start again antibiotic steroid combination along with lubricants, and oral doxycycline will be of help. If not treated properly, this can happen. This patient presented with foreign body sensation, and when checked, the protruding iris was the foreign body, and the patient had to go with a graft. Interstitial keratitis, again, there are n number of causes. I am not elaborating on that. The clue which helps us in diagnosis is stromal haze with the vascularization. And among the causes, except acanthamoeba, all the rest will come down with topical steroids. Just that you have to taper it over a long duration, maybe 6, 5, 4, 3, 2, 1, 6 for 1 week, 5 for 2 weeks, 4 for 3 weeks, 3 for 1 month, 2 times for 2 months, 1 time for 3 months. Like that, do a very slow tapering, let the steroids go on for 4 to 6 months, and then stop and check if the lesion is enlarging or not. Marginal keratitis, this term is associated with many diseases, but typically it is staphylococcal marginal keratitis. Here there will be a staphylococcal blepharitis, and the typical appearance is creamy white elliptical opacities at 10, 8, 4, 2 locations where the lid touches the cornea. There will be a clear lucent zone with the limbus. That is the clue. And as we say, the cliche diagnosed staphylococci do not treat cornea textbooks, so the lesions can be seen in the other place of cornea as well as with minimal lid inflammation. So here the culprit is the lid, so lid hygiene is a must, azithromycin ointment for lids, antibiotic steroid drops for the infiltrate, doxy and lubricants. Another one is rosacea. This will have a lot of systemic features, so it is easy to diagnose. Coming to cornea, there will be marginal keratitis, stromal keratitis and sterile ulcers. If there is a good volume of infiltrate, again go do the scraping, oral doxycycline, antibiotic steroid drops and lubricants. Flictonules, these are small elevated grey-yellow nodules which will be accompanied by a zone of hyperemic vessels. So here again, antibiotic steroid combination and lubricants. Filamentary keratitis, again there are n number of causes, not elaborating. The main culprit is the increased inflammatory component in the tears. So we have to dilute the tears. Remove the filaments if there are many. Give a plain antibiotic to avoid secondary infection, dexpanthenol, copious lubricants and cyclosporin to control the inflammation. If the patient has a lot of foreign body sensation, can advise bandage contact lens. Toxic keratitis, again antibiotic steroids. Chemical injury, eye irrigation, check pH, check for the amount of limbal ischemia. If there are more than 3 clockers, we'll have to go with AMG, or else steroids, lubricants, topical antibiotics. That will be 4 times a day just to avoid secondary infection. MMP inhibitors and ascorbate will help. That was a roller coaster ride, I know. Thank you for the patient listening.
Thank you, Dr. Aneshwara, for that insightful talk. Now I call upon Dr. Bennett. He is working currently as a medical officer in Aravind Eye Hospital, Coimbatore. Over to you, Bennett.
Thank you, Dr. Nadana. So we've been going through serious topics involving conjunctiva, cornea. So my topic is basically lids, lashes and masquerades. So this is a image that I would want you all to remember, because many a times as ophthalmologists, we miss the findings that are usually hiding in the plain sight. So always look out for the most common things that can happen and that always presents before us in the slit lamp. So first I'll be covering the conditions that are that occurs in the lids. This is just a recollection, I don't want to elaborate much. First one is blepharitis. So it's a chronic inflammation of the eyelid margins. We can differentiate it anatomically into anterior and posterior blepharitis. Depending on the underlying cause, we can differentiate into staphylococcal, seborrheic, meibomian gland dysfunction, and angular blepharitis. So elaborating on the signs in seborrheic blepharitis, as you can see collarettes along the lid margins. You can see more erythema and edema in the lid margin in cases of staphylococcal blepharitis. And MGD, which I'll be elaborating later, has got a lot of meibomian gland cupping that you can see. Management, as you all know, it's the regular management, that is warm compresses, eyelid massages, and eyelid scrubs. In few cases of staphylococcal, you can add topical antibiotics, or even sometimes a short course of oral antibiotics like azithromycin. Topical steroids and topical lubricants are kept for cases where the conjunctiva and cornea gets involved. And in case of MGD, thermal pulsation devices are currently available. Next, going into hardiola and chalazion. I'm not elaborating. Hardiola, easiest way to remember from the PG days, we've been reminded. Hordeolum is an infectious condition. It's a pus-filled lump. Chalazion is a sterile lipogranuloma. So the management should also replicate the same. Hardiola externum is in the outer edge of the eyelid, involving glands of Cs or mole. Internum is inside of the eyelid, involving the meibomian glands. So warm compresses is the mainstay of management. In severe cases, you may have to go for incision and drainage. This is just a pictorial representation of same. You can see the external hordeolum, internal, and the chalazion. The next one is trichiasis and dystichiasis. Trichiasis are misdirected lashes growing inward, rubbing the ocular surface. This is usually an acquired condition, and it is usually following cases like trachoma, trauma, or other eyelid scarring. Dystichiasis usually presents with an extra row of eyelashes. Usually, few of them are congenital. Some of them are acquired due to the metaplasia of meibomian glands from chronic inflammation or chemical injuries. The treatment is epilation, electrolysis, and cryotherapy. In few cases where this condition occurs due to entropion and ectropion, you will have to go for lid correction surgeries. Coming to meibomian gland dysfunction, it's a chronic eye condition where the oil glands in the eyelids are clogged, not functioning properly, leading to dry, irritated eyes. Symptoms, as we all know, are burning sensation, redness, flakes and crust on the eyelashes, foreign body sensation, and dryness. Causes are also very well known. Management, again, just like blepharitis, involves warm compresses, lid scrubs, artificial tears. Omega-3 fatty acids were earlier recommended, but later in the DREAM conference, they told it's not causing any significant resolution. Intense pulse light therapy is currently a treatment of choice because it's a day care procedure, and the patient can get it done within 15 minutes. Surgical expression is an older method where manually the glands were expressed in high-grade MGD. So grading of MGD, just want to focus on three things whenever you are seeing an MGD case. See for the expressibility, see for the symptoms of the patient, and see the corneal involvement. You don't have to by heart or kind of stage it accordingly, but whenever the secretion, the quality of the secretion is getting bad, that's when you need to think that you have to treat it aggressively. Sometimes even when you press, but the quality of the secretion might be still, clear and liquid-like, you don't have to go very aggressive with those patients. For plus diseases where coexisting or accompanying ocular diseases are there, you need to treat them first. Going into pre-cellulitis and cellulitis. So the major thing that you need to remember is these. Patient coming with fever, pain in the eye, proptosis, and ophthalmoplegia. These are the sticking out signs. These will be present in orbital cellulitis, which is not just an ophthalmology emergency. It is something that where the patient needs to be admitted and treated aggressively. It can even go into a life-threatening situation. So it's important that you realize what preseptal cellulitis is, that is occurring anterior to the orbital septum, and orbital cellulitis occurring posterior to the orbital septum. Dry eye syndrome is a vast topic. I cannot cover it within this time, but I need you guys to take home something from this. So this is the T-Force2 definition. It's a very large definition. We can break it down into three. So it's a multifactorial disease characterized by unstable tear and ocular symptoms. So the etiological roles are played by tear film instability, hyperosmolarity, ocular surface inflammation, damage, and neurosensory abnormalities. So many a times when dry eye patients come, we always think whatever be the or what goes into our mind, at the end of the day, you're going to give lubricants. You may add some immunomodulators, and you will also treat the lids and lashes. So that's what usually happens in our dry eye disease. But before assessing the patient, you have to ask these questions to the patient. To the patient. That is there a tear insufficiency? You have to look for periocular aggravators, and you have to check the severity. And is there an associated systemic disease? And also, it's very important how the patient perceives the problem. Sometimes the patient may perceive it as a very severe problem, but clinically, you may find it to be a very mild or moderate dry eye. And before the patient, if you take up a very mild stance, patient may think that you're not serious about this problem. So it's important you need to listen to the patient. So these are the step 1, 2, and 3, 3 and 4 of dry eye management. First mainly involves patient education and lifestyle modification. Second step involves treatment of demodex and other ocular surface disorders. Step 3 is necessary where the patient's cornea and conjunctiva starts to get affected. And step 4 where the patient develops corneal ulceration, where you may have to go for amniotic membrane grafts. So an easier way treatment plan for dry eye, I would say, is first treat the symptoms of the patient. It may involve tear substitutes, glasses, and moist sponges. Next, go for the aggravating factors. Find out when the patient is feeling his symptoms. If it's a young patient who is having a CVS, ask him to modify his working habits. Identify the drugs as mentioned. The first talk, drug toxicity can also cause dry eyes. Next, treat the associated ocular factors. This may be seborrhea, staphylococcus, blepharitis, incomplete blinking, nocturnal lag ophthalmos. All this have to be thought about. Then treat the ocular surface. You have to look for entropion, ectropion, trichiasis, lid laxity in old age, inflammation, limbal stem cell diseases. Then go for the systemic factors. As we are listening, autoimmune disorders are one of the mainstay in ocular surface disorders. So if necessary, involve the rheumatologist where the systemic factors have to get controlled. And finally, treat the patient. You'll have to be very supportive, empathetic to the patient, and constantly reassure the patient that it is a long-term management and it will take time to resolve. After all this main disease, I will also like to hint on some of the masquerades that happen in red eyes. The first one is tarsal foreign body. Many a times we miss tarsal foreign bodies. Patient comes with symptoms, we look into the lid, we look into the conjunctiva, cornea, we don't find anything. We just feel the patient is telling a simple complaint. But just a simple step of averting the eyelid of the patient may reveal a foreign body. Sometimes patient will present with a hint, the superior cornea will have an abrasion or some kind of a small ulceration that will give you a hint. But otherwise, even if the patient, if you can't find anything, always make it a habit to avert the eyelid and look for a tarsal foreign body. You can always remove it. I think many of you are aware of a video in YouTube where a patient, US patient presented with 20 contact lenses in a superior fornix. So even few of the patients who are not aware of the right use of contact lenses may have a retained contact lens in their fornices. Next one is acute angle closure glaucoma. I'm not elaborating, only just going to the treatment protocol where immediately if the patient is in an acute attack stage, make them lie in a supine position, use aqueous suppressants, mannitol or acetazolamide to bring down the pressure. Once the cornea clears, go for a YAG-PI. If YAG-PI doesn't suffices and the patient goes for a chronic angle closure attack, the patient may require a surgery. Uveitis is something that we all know. I'm not elaborating again. It's important to rule out infective causes where steroids can be a problem. So always rule out infective causes, and mainstay of therapy is always corticosteroids, mydriatics, and other systemic drugs. Finally, episcleritis and scleritis. So the major thing that comes to mind is how to rule out an episcleritis and scleritis. Easiest way is to use a phenylephrine drop. Always in a 2.5% drop or a 10% drop, you can see the vessels will blanch once you use. That is, patient comes with episcleritis, put the phenylephrine drop, within 15 minutes you can see it resolving. In scleritis, that's not the way that happens. And always use a green filter while you're looking through the microscope, slit lamp. You can see that the deeper vessels well illuminated in the light. So it's very important to rule out, differentiate episcleritis from scleritis. Thank you for giving me this opportunity.
Thank you, Doc. Dr. Bennett, I would like to ask you two questions on the MGD. So, when is this in-office or in-office therapy, that thermal pulsation, cost effective, or is the lid massage still a gold standard? Can you just
So in our practice, whenever the patient comes, it depends upon the economic condition of the patient as well, because the current machine that we have is a LipiFlow, so a single sitting costs the patient around 25,000. So what we tell the patient is that whenever, before advising the LipiFlow, we ask the patient to intensely repeat the uh, lid massaging, that is very dedicated, like as you were telling, many a times the patient are not compliant to this, they just look it like a time pass, something that they do in the free time. So apart from that, ask the patient to do it vigorously. So if the patient is actually improving with the lid massage, you don't have to go for it. But saying that, many of us have actually underwent LipiFlow and actually it makes a difference symptomatically.
Okay, thank you. Now I'll ask Miriam ma'am regarding the drug-induced conjunctivitis. How can we identify drug-induced conjunctivitis?
The first and foremost thing is that we need to take a proper history. See the drugs that they are using, whether they are preservative free. They have chronic conjunctivitis which is not resolving with anything that we are giving. You take a proper drug history and see the drugs. And then another thing is that we need to see the lid signs also, whether there is any erythema around the lid, whether there is any hyper or hypopigmentation around the lid. And most of the signs will be around the lower part of the eye, that is the lower fornix, the lower palpebral conjunctiva. That's how we actually it can give us a clue that this could be a drug induced. And also there will be, in some cases, there will be cicatrizing features like subepithelial fibrosis, like fine if you can remember the slide that I showed, there will be fine lines of subepithelial fibrosis in the palpebral conjunctiva. That's another clue to drug-induced conjunctivitis. Thank you.
I have a question to add to it. Many a times in non-healing infective keratitis, we find patients coming with multiple drugs, like being treated for 1 month, 2 months. So, like the history itself gives a clue that it's already a drug toxic case. So, what is the common consensus about drug holiday that you would give before initiating the proper therapy? Like, is it 24 hours or you would go until 72 hours with preservative-free lubricants?
Yeah, to identify toxicity, it's when we are coming across corneal ulcer, always check for the surrounding cornea. So if the surrounding cornea is almost clear, and you can see the infiltrate is in almost like a greyish white appearance, and you can see the epithelial defect which is never healing. So in that case, it is probably due to the toxicity, that is the ulcer is persistent. In that case, it's often a good choice to stop the drug for at least 24 hours and do a re-scraping and confirm if there is any other pathogens. And in case if it is a lot of inflammation, you can actually give a low dose. The steroids, we can add it. If it again, you should be very sure that there is no pathogens like fungus or an nocardia before starting a steroid. About the drug-induced keratoconjunctivitis, I will ask everybody of the practicing ophthalmologist to just stain your ocular surface. You get lot of clues through this staining practice. It should be routine, I think, because by staining you can actually see the staining pattern in the conjunctiva, which often gives us a clue. usually the drug-induced conjunctivitis, you can see inferior tarsal staining, which is a clue to drug-induced conjunctivitis. Okay, I think any more doubts from the audience? Okay, I think we'll conclude this session, and thank you all for being present during our session.